안녕하세요. 나녹스 주주, 녹스지킴이입니다. 채널 방문해주셔서 감사합니다. 구독과 좋아요 부탁드립니다. 마이클 유즈는 USARAD 홀딩스라는 의료기술 회사를 창업한 인물 중 한 명입니다. USARAD 홀딩스는 미국의 의료진단 기술 분야에서 선두적인 위치를 차지하고 있으며 인공지능을 활용한 의료진단 서비스를 제공하고 있습니다. 이 회사는 라디오 파티클 치료, CT 스캔, MRI 스캔 등 다양한 의료 영상을 분석하고 AI 알고리즘을 활용하여 진단 및 보고서 작성을 지원하는 서비스를 제공합니다. USARAD 홀딩스는 전 세계적으로 고객사를 확보하며 의료기술 산업의 성장과 함께 급부상하고 있습니다. 마이클 유즈는 USARAD 홀딩스를 창업하여 이 회사의 CEO로 일하면서 의료기술 분야에서 혁신적인 아이디어와 서비스를 제공하는 데 많은 역할을 하고 있습니다. 최근에 BVGH에서 발표한 YUZ박사의 DTS, 엑스레이, CT 비교 강의 영상을 보도록 하겠습니다. YUZ박사의 폐암병변진단관련 PT의 대부분은 나녹스의 임상자료가 아닌 외부의 논문등에 수록된 자료를 인용하면서도 나녹스 3D 터모신테시스에 의한 암의 진단 조기발견 능력을 설명하고 있습니다. 자동 번역 영상을 시청해 주시면 되겠습니다. 감사합니다.
Good afternoon and good evening. Thank you for joining BioVentures for Global Health Introduction to Diagnostic Imaging Lecture Series 1. The primary focus of this lecture series is to strengthen capacities in diagnostic performance and image interpretation across the most common diagnostic imaging pathways. In this series, we'll be addressing various topics in ultrasound, X-ray, CT, and tomosynthesis. Here is today's agenda. Today's trainer is USARAD CEO and board-certified radiologist, Dr. Michael Yuz. Today's lecture topic is digital tomosynthesis of the chest, and following our lecture, we will have our Q&A session to round out our time. Please submit your questions in the Q&A box at the bottom of your Zoom screen, and as always, please introduce yourselves in the chat. Now I'd like to introduce and welcome Dr. Yuz. Thank you.
Thank you very much, Carly.
Yeah.
My name is Dr. Michael Yuz. I'm a CEO of USARAD Holdings. We will show the next slide as a required disclaimer.
Do you want to share your screen? I can't see your slides.
Okay. Let me see. Okay, we will reshare it now. How's now?
Perfect.
Okay, perfect.
Can you put it, yeah, in slideshow and...
Yes. Can you see me now? Can you see the deck now?
Yes, it looks perfect. Thank you so much.
Thank you. So this is the slide of the disclaimer, a required disclaimer. I'll just display it for a few seconds. Hopefully this is the most boring slide of the show. I hope everybody was able to read every word. So now we can move to the next slide. This is our agenda. I will introduce myself and my company, and we'll also discuss quickly the digital marketplace. We will then discuss the technological aspects of digital tomosynthesis, also called DTS in short. Afterwards, we will compare digital tomosynthesis with more known modalities to everyone, X-ray and CT. And afterwards, we will review a clinical application of DTS of the chest, and we'll look at numerous cases. I founded the company in 2008 with just one customer, and then I built this company. Today we have hundreds of customers, and we service close to 400 to 500 locations in the United States and even countries outside of the United States. The company is now part of a Nanox imaging, which also includes the AI company called Nanox AI, formerly called Zebra, and of course the marketplace division and the mother division of Nanox imaging, which produces a tomosynthesis equipment and tubes. I'm a board-certified radiologist. I've trained at New York University for radiology residency, and I've also done fellowship at Thomas Jefferson University in MRI and CT. I've also obtained MBA from George Washington University. A little bit about USARAD. We have world-class radiologists, American board certified, and due to an acceptable rate of medical errors and healthcare spending out of control, which overall shortage of global experts, we're positioned to provide this expertise online via telemedicine and teleradiology technologies. USARAD Teleradiology is one of the divisions. The second one is secondopinions.com. With USARAD division, we have a unique model. So we have radiologists available around the clock, and the first radiologist who can available to take the case, who has expertise, will report the case. We're serving all types of imaging facilities, including small hospitals or larger university hospitals of all ranges and sizes, outpatient imaging centers, which are more unique for the United States market, mobile companies, including ultrasound and x-rays, doctor's offices, urgent care facilities, and other type of settings. We are in 4 to almost 500 locations and 10 countries. That includes over 10 countries, including Middle East, Caribbean islands, and Asia, and a few other spots. We have over 300 radiologists, which includes our marketplace division, and we cover almost all 50 states. We do day and night interpretations, emergent and routine studies, and as well as QAs, peer reviews, and second opinions. Now, second opinions, real brief, is a separate division. Beyond radiology, we provide second opinion services in all other specialties, the most common being oncology, orthopedics, and neurology, and a few others, but we have on our panel doctors in all specialties. And today we've provided service for second opinions in over 120 countries. So both patients and third parties can locate us online and upload either images or medical records, and we provide our reports either as a store and forward manner, or we can even consult by video or audio. This slide describes the realities of a current diagnostic imaging market, focusing on X-ray. The graph on the right is the graph from Morgan Stanley resource. We don't have anything currently available. It shows that United States performed about 500 million studies in 2008. So they have not really were able to produce accurately similar graph more recently, but it's very, very interesting nevertheless. We know that actually U.S. volume almost doubled the past 14 years, but the ratio are similar. About 60%, 80% of total imaging is X-ray based. Modalities such as X-ray, CT, mammography, fluoroscopy. And of that, 60% of imaging volume is actually X-ray, basic X-ray. Now, we also know that most spots in the world has very low or no access to imaging. The CT is approximately 10% of total volume. Today, it's very negligible a percentage of full body tomosynthesis which is performed other than mammography. Of course, 3D or mammography tomosynthesis is becoming more and more widespread, especially in the US, but outside of that, it's still relatively negligible amount of current work performed. And we'll explain why later. The current imaging equipment, of course, is expensive, which is a big part of it, and lack of interconnectivity and radiology shortage are some of the realities of today's market. So the global idea that if we can bring tomosynthesis modality at an overall cost and radiation dose which is similar to X-ray, but much lower cost and much less radiation dose than CT, then this would be a really exciting opportunity to bring this modality worldwide. We will now move into digital tomosynthesis technology slides. So here are some basic slides. The image on the right, or graph on the right, demonstrates the difference between conventional radiography and digital tomosynthesis. So on the left, with a CR, you have a single tube and a single detector. On the right, we have you could perform this modality either with a single tube, which rotates with some manufacturers, or Nanox is able to deliver the similar technology using multiple tubes. The idea is the angular sweep of digital tomosynthesis separates overlapping structures, otherwise superimposed in conventional radiography. This is the big benefit of the technology. The next slide demonstrates that there's a short X-ray exposures are made from different positions. So image below shows how the tube moves, and the different positions and angles can be achieved, as I mentioned before, either with multiple tubes in a row or one moving tube. And detector acquires an individual image for each exposure. Afterwards, the computer synthesizes the images and produces three-dimensional tomosynthesis image. This slide describes how images are combined to produce the tomosynthesis result. And the idea is that by shifting the individual acquired images at different cut heights can be created. Okay, we will next move to discuss digital tomosynthesis and how it differs from X-ray and CT, as well as discuss advantages and disadvantages. This slide describes, kind of outlines the main features of digital tomosynthesis and compares it to X-ray and CT. So typically, as you know, X-ray can be done with several images, whilst CAT scan can be from say 50 to thousands of images. And digital tomosynthesis typically you acquire approximately 50 to 60 images, but it could be arranged within 30 and 100, depending on technique and the body part. The reading time for typical X-ray versus CT is between few seconds for X-ray versus several minutes for CT on average, and digital tomosynthesis falls somewhere in between, but it's closer to X-ray in terms of reading time. The radiation dose of digital tomosynthesis is closer to X-ray than CT, and there are numerous papers done that radiation dose of DTS versus CT could be as low as a tenth of a CT, and probably somewhere between, on average, double, 2 to 3 times of X-ray, but still very low dose. The costs, again, this is a sort of average throughout the manufacturers, but the CT, of course, the good CT equipment can range from 500,000 to over $1 million or more for new equipment, and X-ray 50 to 100,000. But the average cost for digital tomosynthesis could be somewhere in between. But of course, the idea that Nanox is to deliver this at much lower cost. The resolution, as you could see, that resolution of digital tomosynthesis is in between the X-ray and CT, but higher resolution than CT. And the other parameters is the disinfection time. Digital tomosynthesis is actually very similar to X-ray. It has a lot less complicated features and components, so which could be important in running the practice. CT obviously is much more complicated, a larger machine, so it takes a lot longer to disinfect. And one other feature here is the metal implant imaging is actually outstanding with digital tomosynthesis, whereas the X-ray and CT, there are some limitations and artifacts. So this is one of the potential uses of the modality. So to summarize tomosynthesis advantages, the technique fills in the important gap between 2D X-ray and CAT scan. The tomosynthesis can be indicated when X-ray is not diagnostic or limited. It resolves overlapping biomass limitation over X-ray. We can reduce false positive and false negative readings compared to X-ray. And as we discussed, the radiation dose is similar to X-ray and much lower than CT. Potential uses during emergencies where CT is not available or practical or excessive. And of course, the price, the cost of running tomosynthesis is much less than CT. Where does tomosynthesis fit? So it fits neatly between X-ray and CT, as we discussed. And there are three types of applications where we could sort of position this modality. The first is when X-ray is not available. I would like to sort of compare this to Chinese market, for example, when they were lacking certain technologies, and then all of a sudden, they are able to acquire electric automobiles, right? So this is sort of similar. So you could jump if you don't have X-ray in third world countries, we can explore, we can discuss why potentially we can avoid X-ray altogether and jump into the more advanced modality like tomosynthesis. So the second type of applications would be adjunctive to radiography, where X-ray is limited. This is probably where in the US market, because X-ray are so widespread, that you could start with X-ray and then obtain your answer or follow up with a digital tomosynthesis and to try to avoid CT. And the third type of clinical application would be CT replacement. Again, where CT is not available, it's too expensive, or in cases in US where it's excessive, where you don't really need all that power of CT. So the first point is obvious, and we will start with the second point, where X-ray improvement, where X-ray is non-diagnostic or limited. Some of the advantages over specific advantages over X-ray include removal of overlying structures, improved visibility of anatomy, detection of subtle lung disease, separation or enhancement of local tissue separation, depth information for structures of interest, increased sensitivity and specificity, and determine other pathological findings which are not visible on standard X-ray. The third type of uses is that a partial CT replacement. This is from pertaining to the slide, where CT is either not available or excessive. So here there's some of the advantages over CT. many studies were done and determined that on average, tomosynthesis delivers as a modality about a tenth of the radiation dose of CT on average, but some studies showed 5 to 20. So various studies show a little bit different results, but on average, approximately a tenth of the radiation dose. Now, the cost factors, again, were observed to be multiple from 3 to 20. And the large size of view sometimes can be helpful. That could be very, very similar to X-ray. And CT, as you know, are typically smaller images. And the workflow is significantly faster than CT. Because there's less images, and radiologists can read it faster, and also the high throughput, similar to X-ray, so you can scan many more patients. We also mentioned that previous resolution is superior to that of a coronal reconstructed CT images, and the flexible position on some technologies, some companies can have a flexible positions. On the right, there's a graph from 2012 Italian study that found that tomosynthesis allows us to avoid the need for CT in about 3/4 of patients with suspected pulmonary lesions. This slide talks about current tomosynthesis limitations versus CT. Of course, tomosynthesis is not equivalent to CT. For example, it's not a modality of choice for abdominal applications, for example, liver or adrenal gland or other solid organ abnormalities, at least with the current available technology. There's a limited angle sweep, which results in anisotropic nature of image resolution. This means that the voxel is not equal on all three planes. So that means there could be some distortion. And most CTs today offer anisotropic nature with an equal voxel on each side, which means that there is less distortion. The other limitations include limited depth of resolution, susceptibility to motion, which could be more so than CT on X-ray. There's no axial imaging available. As you know, a lot of radiologists have been interpreting CT for over 50 years since introduction, and they really got comfortable used to the axial imaging. And currently, there are actually very few experienced radiologists that are familiar with this technology. Not just outside of US, even in US. If you ask radiologists, a lot of them have never really interpreted, even one study. So obviously, this gives us a lot of opportunities from education perspective, as this modality, we believe, will become really widespread worldwide, and in the next few years to come. So now we are moving into, I guess, most interesting portion of the. We have a lot of cases, a lot of images in this section. This is the overview of tomosynthesis applications. Of course, today we will only discuss chest imaging. And then on the right side, a corresponding clinical area. So chest imaging is the most is the area where most of the research has been done to date, and also pulmonologists and radiologists have been working in some centers together on the research and publication and so forth. The next most interesting area would be musculoskeletal, and I know that my colleague Dr. Shapshin will cover that area in a future lecture. We also there are some interesting applications in abdominal imaging, especially when it comes in specialties such as kidney kidney stones, urologic complications, as well as GI. There are some interesting applications in the head and neck area, such as ENT and dentistry, emergency usage, and also there are some research has been done on utilizing digital tomosynthesis during biopsies. First we will cover chest applications that allow us to improve diagnosis over X-ray, basic X-ray. So some of the clinical uses include during a suspected pulmonary nodule evaluation, and the research has shown that various studies demonstrate that the tomosynthesis could be 3 times more effective in identifying pulmonary nodules compared to X-ray. Other advantages include determining subtle abnormalities that just not be seen on X-ray, as well as indeterminate hilar lesions, depiction of additional structures with much better evaluations, such as ribs, calcifications, vessels, chest wall abnormalities, and so forth. This slide demonstrates just one of the studies, which was performed at Mayo Clinic, and shows us that depending on the nodule size, on the left, very tiny nodules, 1 to 3 millimeters, and on the right, over 10 millimeters. So the study found that tomosynthesis is most useful in nodules in a mid-range size between 4 and 8 millimeters, where it almost doubles the sensitivity of detection. So we will look at some cases. This is a case from a 44-year-old gentleman that was referred for chest X-ray due to persistent cough. And I would say that a lot of radiologists would probably read this X-ray on the right as negative study. However, digital tomosynthesis was done on this patient on the right side. Image, it shows a very clear nodule. Now, luckily for this patient, this nodule remained to be benign with a negative PET-CT, and after 18 months workup, they just stopped following, and this was a negative stuff. It was a benign nodule. Next slide shows another case. This is a 45-year-old male with incidentally detected abnormality on a chest X-ray. I would say that most radiologists would probably call this suspicious, or there's something there in the left suprahilar region. But I would say that some radiologists would probably miss it. So in this case, there is no doubt this was a mass. Digital tomosynthesis very clearly showed that there is a mass, perhaps 1 centimeter in size, and this was biopsy proven to be a carcinoid, actually carcinoid cancer, which was removed. The next slide shows us example of adenopathy. On the left side, there's image of a chest X-ray. This is only a 65-year-old gentleman referred for basic for chest X-ray for shortness of breath. Again, I would say that some radiologists would probably not call this, they would probably miss this abnormality, but the digital tomosynthesis was performed on the same date and showed that there is a clear right hilar and tracheobronchial nodularity or adenopathy. I believe this case was a case of sarcoidosis. This patient was diagnosed with sarcoidosis later on. The next slide shows a 55-year-old gentleman who has a history of colon cancer. And chest X-ray shows a nodule opacity, which was confirmed by digital tomosynthesis and then by CT to be a benign plaque. So a case like this, you could probably avoid a CAT scan altogether, because obviously in a DTS, you could see that this was a benign lesion in the anterior wall of the right chest. So no further workup would be needed. This slide we'll talk about pneumonia. Unfortunately, COVID-19 infected hundreds of millions of people and killed over 6 million people worldwide, probably more by now. And pneumonia could be well diagnosed on digital tomosynthesis. This is just one of the examples. This was a younger patient in 40s, and you could see in this chest X-ray there's a vague opacity, which is much better seen on digital tomosynthesis in the middle image, and it was also confirmed, of course, on CT. This is another example of pneumonia. In this example, actually, the patient obtained a chest X-ray, and I believe radiologists missed the finding, but this was a study where they were performing X-ray, CT, and tomosynthesis at the same time, and it was very, very clearly that tomosynthesis and CT, of course, demonstrated the consolidation consistent with pneumonia. Just a few facts about pneumonia. The greatest risk of infection and death is actually in a very young and older patients. I don't want to say that 65 is very old, so try to be careful. And up to over 2.5 million people died from pneumonia in 2017 globally. Pneumonia is a preventable disease. It kills more children than any other infection. And according to UNICEF, unfortunately, a child dies every 39 seconds from pneumonia. So just very exciting possibility in locations where it has no imaging at all, that we can implement modality like digital tomosynthesis and make a difference. We will now look at a few slides talking about pulmonary TB, which is obviously widespread worldwide, especially countries outside of US. Chest X-ray is currently used very routinely to screen for TB. However, the value of screening as a screening tool is reduced by lower sensitivity to detect small lesions, especially nodules, say less than 4 or 5 millimeters. This is an example of a younger gentleman in 20s that actually was diagnosed with TB. On the left, there's an image that shows something vague. I think retrospectively we see it, but I would bet that a lot of radiologists will probably miss anything that's reported as negative, or maybe some vascular shadow. But it's very clearly there's a rounded density in the left mid lung that is consistent. That is consistent with a tuberculosis lesion, a cavitary type lesion. Next slide. The upper portion demonstrates, compares sensitivity of digital tomosynthesis and X-ray for TB-related lung lesions. So the most valuable portion of the DTS that improves the detection over X-ray would be cavitary lesions and bronchiolitis as well. Now, of course, the nodules are also typically nodules in TB could be calcified or larger. So in this study, they saw some significant improvement, but not as much as cavitary lesions or bronchiolitis. And bronchiectasis was also improved. Detection of bronchiectasis was also improved. Consolidation was slightly improved over detection of consolidation was slightly improved over X-ray. On the lower portion, we have another case. This is an 80-year-old man with active pulmonary TB that we see thick-walled cavities. Of course, X-ray does show non-specific, opacities, could be even scarring. but it's really hard to tell. Is it a acute scarring? I mean, sorry, is it acute case of consolidation, or is it a chronic scarring? It's kind of not clear. So in DTS, you see cavity lesions, which implies more of an active case. And of course, this was confirmed by CT. This is another case, pulmonary TB. This is a younger lady in 30s. And this is a more obvious consolidation, which obviously you're not going to miss this on X-ray unless you're blind. Digital tomosynthesis well outlines, but also gives you a little bit better character. You see internal area of cavitation, and of course this was confirmed by CT. So the idea is a potential digital tomosynthesis to become a study of choice for evaluation of pulmonary TB. We will now examine other exciting applications of tomosynthesis as it would with the potential to replace, at least partially, the CAT scan. These are proposed uses. As we mentioned, the tomosynthesis is still in the very early stages, but we hope to change that over the next few years. But these are proposed uses. When CT is simply not available due to cost or other conditions, so cost would be more important in locations like Africa. In the United States, the CT may not be available at the right time, right place. And there are rural areas where actually you have to drive for hours to get to CAT scan. So this could be a very similar situation. Where radiation is of significant concern, of course, we need to limit radiation doses in pediatric patients. This is very important, especially in frequent repeated use, or some sick children that have to have a frequent CAT scans, as well as some of the proposed uses would be in lung cancer screening, and we have quite a few slides on that. Monitoring solid lung nodules, detection and evaluation of interstitial lung disease or chronic lung diseases, as well as emphysema, pulmonary TB, cystic fibrosis, other interstitial lung diseases, including asbestos-related thoracic diseases. So we have a lot of examples of some of these conditions in the next few slides. We'll start with lung cancer screening opportunities for digital tomosynthesis. Of course, the goal is early detection. If we detect cancer, lung cancer, when it's in very early stages, we have a potential to save human life or decrease suffering. So this is the most important goal and most important application, in my opinion, for digital tomosynthesis. Lung cancer continues to be the leading cause of death around the world. I have some statistics from Africa related that the lung cancer cases are expected to double in Africa by 2040. And the African mortality incidence is much, much higher than North America, up to 40% higher. So this is unacceptable, in my opinion. I think we have to do something about it. Out of all cancer diagnoses, 13% are lung cancer. This is pretty alarming. And most cancer cases are detected when patients become already symptomatic and when it's way too late. The lung cancer incidence is, as I mentioned, is increasing, especially among women and younger people. This is not just disease of elderly people who smoke for 40 years. I read CT frequently. It's one of the I'm a radiologist who specializes in MRI, but also a lot of cross-sectional modality like CAT scan and transition to tomosynthesis as well. But I see, last week I saw a patient in 30s with lung cancer. So it's really alarming. It's scary. Now, 80% of cases of lung cancer detected early phase could be treatable with surgery, even without chemoradiation, with survival, with a really outstanding survival. Here's the exciting thing. We actually have the tools to make it happen, to detect and save many lives. So in the United States, the Medicare has had some pilots over the years, and the research showed that it's very effective, especially in patients with high risk factors, such as smoking history or other history of cancers, and also other exposures which could produce could be high risk factor. And they actually, about a year ago, they expanded the use of CT, CAT scan, for lung cancer screening. So now, whereas a few years back, when I remember reading CT, it was very rare to have a screening CT case. Now I see several a day. It's really becoming, really widespread. So I'm very excited, that we're saving a lot of lives with CT as of now. This slide, the next slide, just a little bit more information about lung cancer. As I mentioned before, 2 million deaths in 2018, according to WHO. And the study published in British Journal of General Practice demonstrated or showed that X-ray misses up to 23% of patients with the lung cancer. So this is one of the cases. This is a 45-year-old patient. I don't have X-ray image here, but it very clearly demonstrates cavitary lesion, which turned out to be with speculated features, very suspicious, turned out to be a lung cancer. A few other facts about lung cancer screening. As I mentioned on prior slides, numerous studies demonstrate a clear reduction in mortality using CT. And now we have expanded CT coverage in the US. Low-dose CT screening demonstrated 6.7% reduction in death rate compared to chest X-ray. Positive screening test rate with CT for lung cancer detection of 24% compared to 6.9% for X-ray. Now, here's the good news. Why am I talking so much about CT? Well, that's the only thing we can talk today about, because digital tomosynthesis is not really being utilized to the extent that we are hoping it will be used over the next few years. But they've already have studies that have shown that digital tomosynthesis is a very reasonable alternative to CT for lung cancer screening. Of course, we need more studies, but the future potential of tomosynthesis is really exciting. And of course, I'm excited to participate in the future studies to prove that point, that tomosynthesis can be as effective as CT in lung cancer detection. So this is another case on the right. The X-ray, most radiologists which rate this as negative. However, there's a suspicious nodule which was detected on tomosynthesis and was confirmed on CT. Few more examples. This is a 66-year-old lady who was a heavy smoker, and she went for X-ray for just routine test. Now, again, I would say some radiologists would not call this, but there's a clear lesion on digital tomosynthesis. Retrospectively, you see it on X-ray, but some radiologists would not have called it. And patient went in for further workup, had a CAT scan that had a PET CT, and this was a metabolically active, biopsy-proven non-cell lung cancer. Another case, this is a 55-year-old smoker who underwent chest X-ray, tomosynthesis, and CT. On the chest X-ray, you do have a vague nodular opacity, perhaps around 7 millimeters. I would say most radiologists hopefully would pick this up, but it's vague. Now look at the middle image; it's striking, So it just shows you we don't know what we're missing, with a modality like X-ray 2D modality versus 3D modality, where you can, zoom, go AP dimension, 3-dimensional modality. So it's this was obviously confirmed by CAT scan. Now I'm not sure if this was a cancer or not, but this was an obvious lung nodule that should be followed up for 2 years. The next case shows a much smaller nodule. The chest X-ray, you would not be able to detect this nodule, probably 3 to 4 millimeters nodule. It's obvious on digital tomosynthesis, and of course was confirmed on CT. So this is another case, and the power and value of the tomosynthesis to detect even smaller nodules. Another case, this is a tomosynthesis on the left with a CT on a 52-year-old patient, male smoker. CT confirmed the nodule in the patient, and patient underwent surgery which confirmed malignancy. Patient had also prior X-rays over the past few years ago, and this was a negative case. So another example of this. This might be the last one, example of lung cancer screening. 63-year-old woman with risk factors, including breast cancer history. Chest X-ray was interpreted negative by a radiologist. You do see something vague in that location. So retrospectively, you see there's a little vague rounded opacity. And this is very, as clear as day and night on tomosynthesis and CT. This was confirmed to be a metastatic disease, actually, to a biopsy. I believe this patient had a primary breast cancer. Now let's look at a few other pathologies other than a lung nodule or lung cancers, where we see significant value in tomosynthesis. A little bit facts about COPD. COPD is a leading cause of death in the United States, affecting 60 million people, and a lot of patients with COPD don't know they even have it. Majority are due to smoking, of course. So 3.5 million Americans have been diagnosed with emphysema only. So again, a lot of people don't know they have emphysema. So even mild case of emphysema increase your risk of developing cancer, and other lung conditions and other pathologies. 90% of cases involving people over age 45. Mild to moderate disease is quite difficult to detect on X-ray. So we read a lot of X-rays every day, and X-ray looks normal in mild disease. Severe COPD patients are in increased risk of cancer and undergo frequent CT screenings, which further increase cancer risks. Excuse me. Couple of examples on the right. X-ray, tomosynthesis, and CT. And you could see that X-ray looks negative. We see the emphysema on tomosynthesis, and of course, confirmed on CT. And a mild case on the bottom, you got a CAT scan. You have a little emphysematous bleb, subpleural location, which was well seen on digital tomosynthesis, and there's no way you would pick it up on X-ray. Another slide. On the left, we have a little graph. This was from Japan, the Department of Radiology, Nippon Kukan Hospital. It showed that they did research comparing X-ray, compared digital tomosynthesis, NCT, and X-ray. It showed that ability for tomosynthesis to detect emphysema is really outstanding. It's really excellent and similar to CT, but again, it's hard to detect some of the cases on X-ray. And this is another example. On the left, digital tomosynthesis, you see large size blebs, which are confirmed on CT, and X-ray just you would interpret as negative. Now let's look at interstitial lung disease. It is difficult to diagnose on X-ray, especially in mild cases. Initial follow-up CTs are frequently in these patients, so they do have lots of follow-ups, and which further increase the risk of developing cancer. and there's of course opportunity to replace many of the CTs with modality that with less risk factors. That's about a tenth of radiation dose of CT. So we have a couple examples on this slide. On the left, we have a CAT scan with obvious interstitial lung disease pathology, subpleural location, and lower lungs predominance. We see it really well on digital tomosynthesis. Middle image, and then there's a blow up and shows the parenchyma really well. On the right side, we have another example. X-rays, very hard to detect mild interstitial lung disease. Digital tomosynthesis and CT show that there's a pathology there. Here are a couple of cases of cystic fibrosis. I believe these are the two last slides. So this is a mild case of cystic fibrosis. The digital tomosynthesis on the left shows bronchial wall thickening and mucus plugging pretty clearly. Now X-ray, a lot of radiologists would interpret it as negative. This is the case of cystic fibrosis, but more severe disease. I think in more severe disease, most radiologists would obviously read this as positive. There's wall thickening, bronchiectasis, mucus plugging, but the amount of detail that you see on tomosynthesis really cannot be compared. I mean, it's like day and night. You see a lot of detail. You see, more obvious diagnosis. So I believe I have a last slide that shows bibliography and some references, and this would complete our slideshow. Happy to answer any questions.
Thank you so much for the great presentation. I can speak for myself that I learned so much, and from the chat, it seems like everyone else did too. You got a lot of gratitude, a lot of thank yous, and we have a lot of really great questions for you. So
Sure.
if you're ready for those, I'll get started. Can you see me okay? Just want to make sure.
Yes.
Okay. All right.
I see you well. Yeah.
Okay, great. Our first question is from Dr. Rose. She has a few questions here, so we're just going to go down the line. Have you experienced artifacts on DTS in patients with metallic prostheses, for example, spinal fixation rods or pedicle screws?
Oh yeah, there are artifacts, but they are a lot less severe than on a CAT scan. As you know, CT, you just have a incredible metallic artifacts, which basically render a lot of studies uninterpretable sometimes. But this is orthopedic surgeons really. I know this was not a topic of an orthopedic or MSK, which I'm sure Dr. Shapshin will go into next lecture. But absolutely significant improvement in evaluating the metallic prosthesis, like day and night, and much better than X-ray, by the way.
Great, thank you. Another question by Dr. Rose. How do you navigate through data protection laws and radiologist licensing in various countries when it comes to teleradiology?
Okay, of course, interesting question. Of course, not related to just tomosynthesis, but I'm happy to answer because I guess I would be considered an expert in this area. So it depends on the country. So this is a very mixed environment. So, and it's actually very interesting. I've been from early days when I launched the company. My goal was to deliver the service worldwide. So we've spent a lot of time researching and actually not just researching, but actually working with different countries. So there are all shades of gray here, right? Mm-hmm. So, for example, I'll give you just a few examples. It will be easiest. Turks and Caicos, one example, which is an island in the Caribbean, which is actually run by United Kingdom, but Canada actually institute healthcare. It's very, very strange. And then they have your American radiologists interpret. So they, American board certified radiologists after a couple of months process, the board of Turks and Caicos grants radiologists full license to practice in Turks and Caicos. So we actually provide full final reports, just like radiologist who is from Turks and Caicos, right? Or United Kingdom, because it's under United Kingdom umbrella. Another example would be Singapore. So Singapore, we work under umbrella of Singaporean radiologists. So we would do preliminary reports, and then they finalize our reports. Okay. In some countries, we would not even bother, practice, because like in China, okay, they're not allowed, the government doesn't allow to send images outside of China, right? So even though, we worked with Siemens for many years, it's our original investor, we still work with them very closely. So we made many trips together with Siemens to China, and we signed many deals, but at the end, we decided it was not safe for us to provide any kind of image, service for Chinese patients, unfortunately. But we also provide second opinions. So some countries you can do second opinions, you can do preliminary reports, you can do final. So name me a country, and I'll probably have an answer. But it really depends. Oh, by the way, we do have we've had some experience working in Nigeria, in Africa, and interestingly. Just like in Saudi Arabia, they will actually grant a radiologist either a full license or some kind of a reciprocal to practice and do final reports. So it really depends on the country. So does that answer the question?
Yeah, and thank you for giving examples. We really appreciate that.
No problem.
So Dr. Rose has another question. So in comparison to CT, how thick are the slices in DTS, if I could say that, slices?
Yeah, so we do typically 60 slices in a digital tomosynthesis. And so the slice thickness could be similar or a little bit thicker than a CAT scan. Well, as you know, in the volumetric CT, you obtain the data, 100% of data, so there's no gap. I mean, it's so if you do 60, so I would imagine it's 3 to 4 millimeters, maybe. I'm just guessing. I don't have an exact answer, but I can look it up. But imagine a CAT scan from years ago when they didn't do volumetric imaging. They would do also say 50, 60 slices. So this was between 3 to 7 millimeters, so somewhere in that range.
Great.
That makes sense.
Yeah, thank you. We have another great question. So for chest tomosynthesis, has the patient have to be positioned differently than regular PA, posterior anterior?
Yeah, so interestingly, there are two types of technologies in performance of tomosynthesis. The original, I'll call legacy technology, like General Electric and others, they actually, the machine looks like an X-ray, and they use one tube because their tube is very expensive, and they use mechanical, using mechanics, they move the tube at different angles, and the positioning is very, very standard, similar to X-ray. So if you do chest X-ray, you would be PA and lateral. So it would be very, very actually, if you would see GE or Philips or Shimatsu, it looks like a regular X-ray unit. Now Nanox has something different technology. They use 5 tubes in their machines, so they don't have to move. They eliminate mechanical components, and of course the cost of tubes is much lower. That's why they're able to get, to bring 5 tubes. And there are no mechanical components, or much, at least not in the tube movement. So their position, actually, the machine that they're introducing is supine right now. Okay. But you could obviously put the patient prone, you could put on the side. So that's the Nanox machine looks more like a CAT scan. So position is similar to CT, whereas the legacy tomosynthesis equipment is more like an X-ray.
Great. Thank you for that. Our next question is, in case of suspected pneumonia where there are 3 imaging modalities, is it safer to go for tomosynthesis and CT instead of radiography since X-ray may not pick it up?
So this is a good question. I mean, all these questions are really excellent so far.
Yeah.
But if you have all modalities, okay, and you have suspected pneumonia, from my experience as a radiologist, reading for almost 20 years now, I'm shocked every time I happen to have an X-ray and a CAT scan. So with X-ray, you just don't know what you're missing. And I'm sure every radiologist will agree with me. If you happen to have an X-ray and CT, you see CT, you can have a really significant pneumonia, which just looks negative on X-ray. So my opinion, if you have all 3 modalities, and you were able to, you could skip X-ray, and the idea is to go to tomosynthesis to replace X-ray. So there's certainly obviously X-ray will never go away, but in my opinion, tomosynthesis is just so much more powerful, and it really, really fits right between X-ray and CT. It's not a CT. It'll never be a CT, but it has so many indications that you can really eliminate both X-ray and CT.
That makes sense. Absolutely. Thank you for that answer. Our next question is, does CMS cover chest tomosynthesis for lung cancer screening? And for those who don't know what CMS is, it's the Center for Medicare and Medicaid here in the U.S. So it's a very much U.S.-based question.
Great question. At this point, it does not cover tomosynthesis for lung cancer screening. We have one CPT code that is sort of a generic CPT code that's used to cover for basic indications with approval, where a clinician states that, yes, I need to further work up a suspected lesion on X-ray, so they usually start with X-ray, and then there's a code that it's actually old tomography code that American College of Radiology stated that, yes, this is a approved code. You could use it for tomosynthesis as a general, and the indications are typically for lung lesions or suspected lung lesions, as well as musculoskeletal applications. Suspected fracture, that's, you cannot tell for sure on X-ray. So there are some limited approvals, with one CPT code, but we're at the very early stages. So there's a lot of work to be done, and of course, there's an exciting possibility, and we're going to be hopefully part of that in trying to approve more indications, more CPT codes over the next few years.
Great, that's good to hear. Thank you. Yeah. Our next question is, can you create 2D synthetic CXR images from the DTS images? Absolutely, yes.
There's some research going on right now of taking 60 tomosynthesis images and creating a very nice, clear X-ray image in a similar fashion to we do with mammography, 3D mammography, and we reconstruct. So this is a very astute, question, and I'm very pleased with the questions today. But yes, it's possible. Still needs more research, but I know that some companies are doing it. So these are very early days for this modality. As you know, everything in healthcare moves very slow, and costs have a lot to do with it. So I have questions as well. Tomosynthesis has been around for some years, maybe even 10 years, but I really haven't heard of it. Well, if it's very expensive, and the reimbursements are dropping in the US, then you need to do something about it. If you drop the costs, because the benefits are obvious, but the costs make it very difficult for facilities to obtain the equipment. But if you drop the costs, of course, that will change the game. It will change everything. So.
Absolutely, especially for the patient, of course. Right. The most important.
Absolutely.
Our next question is, well, first they want to say thank you for the enlightening lecture. From this lecture, I think DTS can replace CXR as a screening tool for pulmonary tuberculosis, especially in endemic areas like sub-Saharan Africa. What are your thoughts about that?
I agree 100%. I think, especially with a prior great question, can you reconstruct and make an X-ray from tomosynthesis? And you can, and you'll be able to, with some more research and more data needed, of course. But I actually agree. The uses of 2D X-rays, down the road may be limited. I mean, other than the costs, maybe you have equipment that you already purchased and you don't want to replace it, things like that. But I think that as I mentioned in China example, you can leapfrog technologies and go to the next best thing if you can lower the costs. And I think we're hopefully getting there very soon.
Great, that's a great answer. Our next question is, how would a pneumothorax be picked up on DTS, if at all, and any radiographic characteristics that you could describe in that regard?
Right. So up until now, we don't have a lot of examples of using tomosynthesis in a emergency settings. Although, of course, we know this will be possible down the road with a widespread use. But just I would say that a small pneumothoraces are very difficult to cover on X-ray. So just like example of emphysema. Now, I don't have any examples of pneumothorax, but I would say large pneumothoraces are easy to pick up on X-ray, but small are not. So tomosynthesis can absolutely play an important role in the pneumothorax. And even pneumomediastinum down the road, of course, you would need a upright positioning, make sure patient's standing, and so there'll be certain conditions, to pick up those emergencies. But yes, I don't see why not that it could be used in a emergent settings like pneumothoraces.
Great. We have so many questions, so thank you so much for being so gracious and answering all of these.
We still have at least 15-20 minutes, so that's
yeah,
good.
we do. But I just want to say thank you so much for answering all these wonderful questions. This next question, can DTS replace bronchoscopy at any point, you think?
Bronchoscopy?
Yeah, the direct visualization versus, the more invasive, detection.
Well, listen, this is a non-invasive procedure, so I don't think it can, replace the actual procedural portion. Mm-hmm. But think of it as more like a CAT scan. I think it can avoid a lot of unnecessary procedures. Just like when you go from X-ray to a CT, you can go from X-ray to the tomosynthesis, and of course you can avoid some procedures. Now, one of the reasons sometimes you avoid CT because radiation, you don't want to already the patient, with frequent follow-ups. And I know sometimes patients opt for, okay, let's do a biopsy, right, or bronchoscopy. But because DTS the radiation is so much lower, I think in that case, one of the examples where you could probably avoid some procedures and biopsies and bronchoscopies, because you could follow this nodule or whatever the pathology more frequently, right? Right. Just like an X-ray. I mean, nobody talks about X-ray. People can get sometimes tens or even hundreds of X-rays in a short span, right? Depending on how sick they are. But nobody will do CAT scan 100 times, right? So with DTS, you can actually do a lot of follow-ups with a lot less radiation. So yes.
That makes sense, and preventing unnecessary procedures is always a good thing to strive for. Thank you. Our next question, would radiologists have to undergo months to years of extra training to interpret DTS results, or would the knowledge of conventional radiographs suffice?
So that's great question. And of course, under my supervision, we have quite a few radiologists, and I've been working with few already and showing them the modality. Some have never, most of them have never seen it. So this is the exciting news. The learning curve is very fast. So especially for those radiologists that know CAT scan already, because looking at tomosynthesis is very similar to looking at coronal CT. So those with CT experience, I would say they can pick it up within literally a day or two, like really fast. So if you have enough cases, they can go right away. Those that never really interpreted CAT scan, more of a general radiologist that read X-ray, I would say the curve may be a little bit longer, but still very short, maybe a couple of weeks, and they have to see enough cases, and I think they can start interpreting, with a very good confidence. So yes, that's great news. It's actually looks more, threatening than it is. I mean, because people are afraid of new things, but sometimes some things are really have a very high curve, like tomosynthesis. So no, it's going to be a pretty fast curve.
Great. I'm sure everyone's excited to hear that. Our next question is there a way to upgrade a chest X-ray machine to be able to do DTS, or is this a new machine that needs to be procured?
Yeah, great question. It depends. If you purchased a tomosynthesis in the past couple of years, and there's an option to upgrade it, then it's a possibility. So you should contact your manufacturer and ask. And some of them are, I know that you could purchase with a possibility to upgrade in the future. So, but I think it will be most likely, probably if you have older machine, probably not, but it's for some new equipment that yes.
Great. Thank you. Our next question, another great question from Dr. Rose. Thank you, Dr. Rose. Do you have experience using DTS in pediatric chest imaging? And she asked because the immense benefit of low radiation doses in DTS compared to CT, especially with kids,
Absolutely, great question. I personally do not. I think in general, very few centers have experience. Also, don't have a lot of experience. Most experience today with adult population because it's been used more in a research setting and kind of like still in evaluation stage. So I think there's a lot of exciting possibilities to start using it in pediatric in the very near future. But I do not to answer the question.
Great, thank you.
No problem.
Like you mentioned earlier, the learning curve is going to be a lot smaller, which is great news. Would you say that the language to interpret these images will also be the same as an X-ray or easy to gain? Okay,
so I think the question relates to reporting, how you structure reports. Mm-hmm. Yes, so we have some templates, and so it's somewhere in between X-ray and CT. It's not as the templates or the report structure. They're probably more involved. They look like more detailed like a CAT scan, but not as much as say CT, but somewhere in between. And it's very easy to adapt. And it's part of what we'll be doing is training and providing the examples of reports and so forth. So hopefully that answers the question. Yes. So it's in between X-ray and CT in terms of the type of detail that you can report on.
Great. And this question is more a USARAD question, actually. So I want to save this towards the end.
Sure.
How many tomosynthesis reads other than breast has USARAD done, say in 2022?
Well, we've only looked at in a research setting, so we've not actually, none of our customers yet have the actual equipment. So we've been only looking at in the research setting and teaching purposes. So in terms of prime time, USARAD has not interpreted any official tomosynthesis studies, only in a, as I mentioned, a research and a learning setting. Yes, we're all getting ready for exciting future.
Yeah, but you essentially your business is reading all different types of modalities. So I'm sure countless amount of reporting on your end in terms of your business.
Yes. We've obviously we interpret all type of modalities, from X-ray to MRI and everything between. So we're actually excited to start, interpreting tomosynthesis. We've done a lot of internal training and some material and so forth. But yes, we are excited that the new modalities come into town. So.
Great. We've gotten a lot of questions about cost or how we can get DTS in Nigeria. What are the, I guess speaking from USARAD or Nanox, what does that look like? Or I know you could make upgrades to your current X-ray machine if possible, but what does that look like?
Well, just in general, you could contact your manufacturer. There are several companies that make tomosynthesis: General Electric, Shimatsu, and so forth. Carestream, I believe, as well, and a couple of others. And they are FDA cleared. So if you've purchased one of those machines, you should contact your manufacturer and see if they can upgrade it. Of course, they are not cheap; they're expensive machines. And tomosynthesis does have extra costs. Nanox is waiting for FDA clearance, and then CE clearance as well down the road to be able. So they're not, in some markets, I think that do not require FDA and CE. I believe they could ship some of the machines already, but not in US or Europe, for example. So they can contact Nanox and find out details of your particular situation or country. But yeah, those are the several routes that depending on where you're located.
Great, thank you. Well, there's a lot of questions here, and you answered a lot of the questions I'm not asking via your lecture, and I'm happy to share lecture slides in the video and in the days to come with our attendees, so you can get those questions answered. But I just really want to thank you for your time and sharing your expertise. I learned so much, everyone learned so much, and that's why we're here. And so just really want to extend my utmost gratitude and just a big thank you to you and your time today with us.
Thank you very much, Carly, and the whole audience for this opportunity to provide this introductory lecture. Hopefully we'll do more lectures. But yeah, we're very excited. The possibilities are really endless to bring this modality to worldwide in a more widespread fashion than previously. So thank you again.
Thank you so much. And I wish everyone a wonderful evening and a restful weekend ahead. And thank you again, Dr. Yuz. It was a pleasure.
Thank you very much. Thank you, Carly. Bye-bye.
Bye.